Hello and welcome to Checking the Vitals, a podcast powered by SpecialtyCare. Today our guest is Dr. Peter Wagner, an orthopedic surgeon at Orthopedic Partners in Niantic, Connecticut. In this conversation, we discuss why he chose to go into orthopedic surgery, what the residency process is really like, and how that process and the graduated autonomy it provides helped him prepare for orthopedic surgery. Enjoy the conversation. I like to start off all the podcasts with finding out what it was that drove each person we're talking to into the medical field. So was there a key moment in your life, maybe early life or young adult life, that you had sort of the epiphany of, I think I want to be a doctor?
Yeah, I think for me, it was sort of more of a gradual thing. So when I was in high school, I was kind of gravitated towards the sciences. I was fascinated with the human body. I went off to college. I was a biology major. And sort of the more classes that I took, the more I kind of learned about anatomy, physiology. That kind of drove me towards pursuing a career in medicine. My father was, or is, an OBGYN on Long Island.
Okay.
So small town doctor, treated a lot of people in the community. You couldn't even go out to CVS or a restaurant without running into one of his patients. So, I saw how appreciative they were. But if anything, I think my dad actually probably discouraged me from going into medicine a little bit more, just because when you're a surgeon, you're kind of married to your career more than anything else. So, a lot of emergencies at the hospital that took him away from family time, things like that. But you also saw at the same time the rewarding aspect of the field too. But it's sort of more of an organic process for me, I guess. So
I have talked to a lot of surgeons whose fathers were surgeons, and all of them have said that their father, who was a surgeon, told them not to be a surgeon.
Yeah, it's interesting.
So that's an interesting parallel. I mean, every one of them has been like, go into business, don't do surgery.
Right.
Yeah, because I think at least the common, and this is very anecdotal because I haven't interviewed every surgeon that had a surgeon father, but they've all said you want to have people working for you, not to be working every day.
Right.
But the people I've talked to that are surgeons they're the people who want to be hands-on.
Yeah.
They want to be in there seeing the impact of the patients, and I imagine that's what kept you going and wanting to do it.
Sure. I think for surgeons, I think we all like having a physical skill that we can perfect over an entire career. So we're always constantly improving our technique. We're always finding new and efficient ways to do things. To a certain extent, we're kind of blue collar too. We're just like carpenters and electricians and plumbers even too. We're trying to do things more efficiently and treat patients. So that was sort of what I liked about it. When I was in my training, initially I actually thought I wanted to be a pediatrician, just because I loved kids. And that was very fascinating to me. But then as I went through my clerkships, I walked into the operating room and just realized that was absolutely where I wanted to be. This was the place where all the magic happens, where you make immediate changes to people's health. And orthopedics was exciting for me because it was mostly about pain and function. So the procedures made sense to me. You have somebody with end-stage arthritis and you do a hip replacement. If you take the arthritis out, then they get better. You can see dramatic differences in people's health and function. So
and
that was
sometimes very
exciting.
quickly.
Oh yeah, absolutely.
Yeah.
I mean, there are some times when, if people have an acute disc herniation and like a really red hot radiculopathy, leg pain, sometimes they undergo surgery and they're in the postoperative area and their leg pain's completely gone and they're happy. They just had spine surgery, but they're in less pain than they were prior to surgery. So that's the rewarding part.
Awesome. You graduated college when?
2006.
Okay, so did you go right into med school at that point?
No, so I got a master's program, master's degree first. It was a master's in medical science. It included a research component, so I did some small animal research looking at neurochemical pathways in the brain, mostly hunger satiety pathways.
Interesting.
But that was sort of my first foray into neurosurgery, actually. So started thinking about where the lesion is, the result of the lesion and sort of the objective deficits and function. And then after that, I matriculated to med school at Drexel. So I got my master's program or my master's degree at Drexel, and then I did medical school at Drexel as well.
So when you apply to Drexel and get into Drexel, did you know at that point you wanted to be an orthopedic surgeon, or were you still thinking neurosurgery? Or?
No, so I was kind of I was keeping an open mind. I thought at first maybe I wanted to go into emergency medicine, and I considered pediatrics for a short period of time. I was always fascinated with neuroanatomy, both when I was an undergraduate and then when I was taking the classes in my master's program as well. So that kind of interest, I think, permeated through my medical training. But really, it wasn't until kind of that first day of my surgery clerkship when I walked in the operating room and realized that was where I wanted to be. So,
yeah. So you decided you want to be an orthopedic surgeon, and you apply to a residency. Which residency did you end up?
Yeah, so I wound up going to the University of Massachusetts in Worcester, Massachusetts. Okay. So really high volume trauma center, biggest trauma center in central New England. So we were a big tertiary referral center, and did a lot of cases, and it was great training. I mean, we did everything from arthroplasty, trauma, foot and ankle, spine. We had a lot of elective procedures. Sure. We had a lot of emergent procedures. So. A lot of surgeons to learn from, a lot of people with very unique backgrounds, so it was a great place to train.
I've heard that, and you mentioned it's a very high volume center, that is sort of a sought after component of a residency or even fellowship, because you want to, it's sort of like a sport. You're trying to get as many reps as you can, because with that, you learn a little bit every time. Yeah. So you're never going to do it perfect every time, but you want to get as close to that as you can, and it takes practice to get there.
Oh, absolutely. I mean, I think the more cases you do, the better you get at them, and especially with something like orthopedics that it's so trauma oriented. You want to work at a place that has a tertiary referral center so you can really crank out a lot of reps with regard to trauma cases, and just get better at them every single day.
Yeah. So you did that. Residency in Massachusetts, and then you did a spine fellowship, correct?
Yeah, so I wound up doing a spine fellowship down at Brown, Rhode Island Hospital. So I actually stayed, I was living in Worcester at the time, we never moved, I just commuted down. And it was great. I mean, Rhode Island Hospital, very similar to University of Massachusetts in Worcester, is a very high volume center as well. So they did a lot of spine cases. I did exclusively spine, and really kind of perfected a lot of the techniques there. Worked with some of the best surgeons in the country at Brown, and got great training.
So was there something about the spine that made you want to focus on it, or instead of foot and ankle? Or
yeah. I think the neuroanatomy was really intriguing to me. I like the idea of offering people potentially small solutions to really big problems. So people who have disc herniations, radiculopathy, thankfully most people have kind of mild symptoms that respond to non-operative treatment. But for those people who just have really severe symptoms, they just can't do anything. They have severe arm pain, severe leg pain, they can't work. And for those people that, fail non-operative treatment and go on to surgery, I think the surgery is very rewarding because they can get sometimes very quick results. And there's a lot of data that says that, surgically treating people with radiculopathy, and people who failed non-operative treatment, they get back to work faster, they get back to their life faster. So that was a really rewarding part for me.
And I'm sure you've dealt with this too, but I've talked to a lot of orthopedic surgeons who say that their patients seem to be happier with them than other surgeons' patients, because you come in with severe chronic pain, and you go into surgery, and 2 weeks later, it might not be completely gone, but it's significantly reduced. People just respond to that so well because it's changing their life, really.
I mean, people love the orthopedic surgeons. I have to say, everybody has back pain, knee pain, hip pain at some point in their lives. So, everybody at some point is seeing an orthopedic doctor for their needs. And, it's funny, when I was going through medical school too, I get together with my family over Thanksgiving. The only questions they ever had for me were orthopedic issues, like what do I take for my aching hip, my aching back? How do I fix this? Why aren't you going through training faster? You can give me more information.
Is there a friends and family discount?
Right, exactly. So, I think orthopedics is a really, it's a great field. It's optimistic. It gets people back to normal activities of daily living.
Yeah,
so
absolutely. So you have recently come through all of these programs. You're not 30 years removed from them. So I'd like to actually talk a little bit about what it was like to sort of day one on specifically your residency. So you graduated med school. That's an accomplishment in and of itself. But you're going into a residency that is all about orthopedics. Day one, is that a daunting day one? meeting all these people who will then be your mentors and
Sure.
people who are guiding you throughout your career, it's got to be just a little bit of a daunting to walk through that door on the first day.
Yeah, I think with medical training, every year that goes by, you sort of, especially in residency too, when you're an intern, you go in knowing almost nothing about orthopedics. I mean, you learn things in your clerkship, but you don't get any practical skills.
Right.
You have very little hands-on experience, and you learn that over time. And then, by the end of intern year, I think most people say, I think I figured out intern year, but you go on to your PGY2 year and then you start anew again. And you have no idea how to be a PGY2. And each year is meant to kind of give you that additional experience. But, you sort of hit the reset button over and over again. And there's a reason, I think, why training is, structured the way that it is, because, orthopedic surgeons recognize that each year is important and gives unique, skill sets
and probably perspectives.
Yeah,
too.
Absolutely.
Yeah.
But yeah, in the beginning, it's definitely daunting. You try not to make mistakes. You always bump up any issues that you have to your senior residents, to your attendings.
Mm-hmm.
You're probably calling more frequently than you would be otherwise later on in your training, but that's just to make sure that you're doing things correctly.
Sure.
And you're doing things under more direct supervision, but eventually there's this graduated autonomy where, as you get more experience, you get a better skill set, you feel more adept at treating patients, and then you get to be a little bit more independent.
Sure. Yeah. So, and forgive me for not knowing, but do you start getting hands-on in surgery like your first day of residency?
Yeah. So, usually when you're, starting out as an intern or a junior resident, a lot of that is floor work, ER consults, things like that. So in orthopedics, it's reducing fractures, wrist, ankle, putting in skeletal traction, temporizing people for surgery. You do get some operative experience in the beginning, but usually you're with an attending surgeon and a chief resident. And the chief resident lets you do certain parts of the procedure, but primarily in the beginning of your training, you're doing mostly floor and ER work, just to kind of develop a skill set. And you're sort of talking about surgical indications and learning, which people need to go to the operating room, what your different surgical options are. And then once you sort of get that knowledge base, then you get more exposure to the technical aspect of surgery.
Yeah. So the residency for orthopedics is 5 years?
Yeah, so mine actually was 6 years. I did a year out to do research. It was part of the pathway at UMass. So if you wanted to, you could actually apply for a separate track that included a year of research. So I did exclusively spine research. So we looked at outcomes-based research. We looked at spondylolisthesis, had the ability to travel for meetings, present at meetings.
Awesome.
I had some papers. So it was a nice foundation kind of leading into my training, and I think also helped me sort of develop an interest in spine surgery too.
Yeah, so and is there an option to not do the research year? So you can do either track.
Yeah, and I think UMass is unique in that there might be a couple other programs in the country, but it was definitely a unique feature of the program that kind of attracted me to it.
Yeah.
You still maintain some clinical experience, you still take some call, but primarily it's a year out doing clinical research.
Yeah. So. Is there a benefit long term for having that research year? Because I'd imagine, and correct me if I'm wrong, obviously, but right now you're practicing sort of every day. Every work day you're either in the OR or prepping someone to be in the OR.
Yeah.
And so how does that research or having that extra year of research kind of inform those later career years?
Yeah. So I think definitely gave me a foundation for spine care, but it also sort of taught me to look at research critically too. So once you sort of are a part of a research project, I think you understand the ins and outs of how research is formulated.
Sure.
You understand big data, and it gives you a little bit more of a critical perspective on some of the literature that comes out. I think that we're all data-driven people. We all like to make decisions based on evidence. And if you can interpret it a little bit more effectively, I think it gives us a little bit more insight into treating our patients. So.
Yeah. And I'd imagine, maybe not in any other field in surgery, but a lot of papers come out, a lot of research comes out every year. So you have to know how to digest that information and make it not just readable but usable for you.
Sure.
And keep up to date with all that stuff. So I'd imagine just having that 1 year of research really helps you with the digestion of that.
Sure. And you have to be critical of research too. Not every study needs to change our practice, but I think over time, if you see a lot of the same conclusions being drawn, then eventually we start to change our practice. But you have to be careful about as with anything, there's always bias that's introduced to research, so negative studies tend to get published less. So studies that don't show a difference between two outcomes that was meant to demonstrate a difference, that tends to not get published as frequently. Whereas people tend to focus on the single paper, maybe out of 8 papers, that showed a difference with something. Well, that doesn't necessarily mean you need to be changing your practice, because there's all this other data that says that these two outcomes are equivalent. So I think it definitely gave me a unique perspective to treating patients.
Yeah, that's interesting. Like, I would never have thought that. I mean, I remember growing up, eggs were things you were supposed to eat and then not eat, and then supposed to eat again. So I'd imagine that there's an equivalent of that in the surgical community that's not so maybe dumbed down.
Yeah, I mean, if you talk to any surgeons or even other medical doctors too, you never want to be the first person to adopt something, but you don't want to be the last person. So there's a healthy intermediary, So I think we definitely want to adapt as medicine changes and we get new information, but you don't want to be too quick to adapt something that hasn't had proven efficacy yet.
So let me ask some questions about that sort of innovation and technology as it's moving forward here, because there are a lot of advancements that have come out for orthopedic surgeons, and I wonder, and this is completely anecdotal again, just because I haven't talked to every surgeon out there, but I've noticed that it seems like the younger surgeons are more apt to adopt new technology, and is that something that you've seen as you've come through, and do you have a theory as to why that might be?
Yeah. I mean, I think as surgeons, we try to do things consistently. So the same way every time, we treat thousands of people and we try to, come up with reproducible results. So, as we kind of get out in our careers, we find a way that works for people. We find a way that produces consistent outcomes. I think the trade-off to that is that maybe you're a little bit more resistant to new technology. I think one of the advantages of being kind of a young surgeon coming out into the spine field is that, I've trained with people who have been doing the same surgery for 30 years the same way every single day, and they get reproducible outcomes. But I also see some younger people that I was working with in my training too, who are adopting some new technology, who find creative ways to deal with patients in a kind of slightly different way. So minimally invasive spine surgery, lateral procedures, microdiscectomies, using robotic technology. Those are all things that are kind of new to the field, but they've been around for years. So just sort of, reaching the point where they're becoming more widely accepted and adopted. And I think it's exciting for people. It allows us to treat people's pathology in a very unique way. Not everybody's spine is the same. Nerves can be pinched in a variety of different locations. It can be multiple levels. You can have older people who, you worry about doing bigger procedures on them. But we can find creative ways to deal with their problems while minimizing complications.
Yeah.
So,
I mean, ultimately, at the end of the day, you're just trying to mitigate any kind of bad outcome and improve quality of life. So any tool that comes out, any technique that is discovered to help that, but again, with that research aspect, you got to know what research is good research, and whether you should change your practice or not.
Yeah, absolutely.
And you mentioned robotics when you were talking just now. Is that something that you may have just sort of grown up with that in your residency and fellowship? Yeah. So is that something that you've adopted pretty wholeheartedly?
Yeah, so we're actually, we just had or developed a new robotic system at the hospital I'm working at now. It was something I had exposure to when I was training. It actually, when I started my training, it was not a technology that was readily available. It was sort of in its early inception period. But over the course of my training, it became more readily adopted. And it's a nice tool for patients. There's a lot of data that's coming out that says that it improves screw accuracy, minimizes OR time, minimizes intraoperative radiation. It's a nice option for people who say have, one area in their spine with nerve compression, but otherwise have multiple areas of deformity in their spine. So, you really only need to do an open procedure for the area where the nerves are pinched that lead into their legs, but you can correct their deformity percutaneously while using either intraoperative fluoroscopy or robotic technology. And it helps us to, minimize surgical morbidity while still taking care of the problem at hand.
Sure. So. And I've heard that robotic procedures can tend to be faster, so there's less time for the patient actually on the table, and that can help improve results.
Yeah, so the technology that, and there's a couple different ones on the market, but basically what it requires is, everybody gets a preoperative MRI prior to surgery just to, show where the nerve compression is, but also people who are candidates for a robotic procedure get a preoperative CT scan, and we use that. We actually, the software localizes off the patient's CT scan, and there's a robotic arm that comes in, and you can pre-plan all your screws at home. So they have software, you use it on an iPad or on your computer, and you can literally plan out your surgery sitting on the couch at home, and you show up the next day and you just execute it in a timely fashion. So you know exactly where your screws are going, and you use the technology to make sure that they go exactly where you want. And there are other strategies that we use in order to make sure that our instrumentation is perfect. Intraoperative fluoroscopy, knowledge of anatomy, things like that. But this is just another tool that can, you know, help minimize OR time and complications. So.
Yeah, and just help it run more smoothly, I'd imagine. Mm-hmm. So with that, because I mean, screw placement is obviously very important in those types of surgeries. How much wiggle room is there for how exact that screw needs to be placed?
Yeah, sure. So that's a good question. It depends on what level you're operating on. There's obviously, it's less forgiving at spinal cord level, but, you know, in the lower lumbar area, the spinal cord is terminated and all the nerve roots are in the thecal sac. So you're not doing spinal cord level surgery. And, you know, the pedicles have different diameters at different levels too. So at L5, for example, the pedicles are usually larger. So you can tolerate a little bit more variation in your screw trajectory. But, you know, at thoracic levels and cervical levels, things like that, we tend to use more either X-ray intraoperatively or some sort of navigation technology just to ensure that the screw position is perfect. We get good fixation. Yeah, absolutely.
Yeah, absolutely.
You know, there are a lot of different ways to achieve that. But I think robotic technology is exciting because it, you know, it sort of takes out a couple variables basically, and it helps you ensure that you're, you know, getting them in the right spot.
Sure. So you graduate your residency and your fellowship, or finish your fellowship. Did you immediately go into private practice? And that must have been recently.
Yeah, so I've been in private practice for a few months now. I finished my fellowship in July. Yeah, it's been nice. You know, practice building has been getting busier. You know, the good thing about where I work right now is that my private group has a very good reputation in the area. So they have a good referral base. But I get a lot of referrals from my partners too. You know, the thing about spine is that spine disease is very prevalent in the community. So, you know, a lot of times people will see, say, my sports partners and they think they have a shoulder issue, but it turns out they have a pinched nerve in their neck. So, you know, my partners will refer to me for, you know, further management, treatment, things like that. But yeah, it's been exciting. It's nice to get a little bit more independence, but I also get a lot of support from my partners. You know, it's we always talk about our cases and patients that we're seeing and review imaging and surgical plans. So it's nice having that support within the group too.
Absolutely. Yeah. I'd imagine that all through residency, through fellowship, there is a little bit of a safety net, maybe less of one as time goes on. Sure. But now that you're through all that and there isn't so much of that safety net, is that a scary process, or do you feel well prepared for it? I mean, you have to be well prepared. You've got years of training.
Yeah, no, I definitely think, you know, there's, as with any training program, you know, you have some graduated autonomy and, you know, the goal is to get you independent, but there's always people who are, you know, able to help. And, you know, as with spine too, there's a lot of different ways to approach problems to it. So I think the big thing is just having mentors that you trust, people who like talking about surgical indications and just reviewing your surgical plan. I think, you know, part of your residency and fellowship training is learning how to execute that plan safely. But I think the minutia of decision making is a thing that we're always trying to perfect over time. And as new evidence comes into play, we're trying to perfect our technique and indications. But I think being a part of a private group that has both general orthopedic providers, but also other spine providers who sort of have a unique perspective on things, is nice to kind of develop your own style and approach to patients.
I was going to ask, because you did enter a group where you're not the only one who does what you do. And in fact, there are other doctors who do things that are not exactly what you do, but are around that same area. So there's got to be a wide depth of knowledge in that group. So if there's ever anything that comes up, do you guys have that sort of relationship where you could just pop into their office or give them a phone call and say, hey, I have a question about this case? Or whatever.
I mean, my partners, you know, I see patients at the same time, you know, sometimes down the hallway, some of my other spine partners. So I'll literally walk down the hallway and pull up some imaging and talk about a case, or, you know, kind of review surgical plans. And, you know, the thing about spine though is, you know, if you ask 3 different spine surgeons what to do for a certain pathology, you'll get 3 different answers and sometimes 4, you know. So there's a lot of ways to approach pathology. I mean, I think the basic principles of spine are we need to decompress compressed nerve structures and then stabilize structures that are unstable. So there are a lot of different ways to do that. So we can really kind of tailor our treatment plans to the patient and what their expectations are and what they would like to proceed with. But I think it's also nice to have a consensus in the group too.
Sure.
So having other people that treat the same problems routinely and have a different perspective on things is always helpful for making sure that you do the right thing for people. So.
Yeah, you've gone through all this residency, all this training, and you have always had sort of a safety net through that process.
Yeah.
And now you walk into an OR and you're sort of the leader of that team.
Yeah.
Was that transition daunting at all?
Yeah, so I think in medical training and surgical training, it definitely happens gradually. There are instances where you get a little bit more autonomy under direct supervision, and then as in fellowship, you're treated like an attending in many instances too. So, you start doing things more independently, taking people to the operating room, always reviewing your surgical plan, and always knowing that there's kind of somebody more senior to you around the corner in case you need some assistance. If there's a challenging part of the procedure, things like that. So so being out, in practice right now, it's different because I am a little bit more on my own, at least technically speaking, in the operating room. But the good thing is that I always have people immediately available for advice. I have a great group of people I work with in the operating room, anesthesia providers, surgical representation for my instrumentation, scrub techs, things like that. People are proficient in the procedures and make things move very smoothly. So, I don't think that surgical training at least throws you into the mix immediately. It's definitely a gradual thing.
Yeah.
But once you've demonstrated proficiency and safety, I think a lot of that is sort of developing your own skill set and confidence and sort of applying that. And I think it's exciting coming out in spine right now.
Yeah, absolutely.
Yeah.
So I'd like to close with one final question. And since you are so closely removed from your training process, if you were talking to someone who maybe, let's say, graduated with a med science degree or a bioscience degree on some level from college, and they were considering going into medical school, what would be sort of your sales pitch for saying, hey, you should do it?
Yeah, so I think, you have to understand what you're getting into. Medical training is a long road. Residency is a long road. You're working, 100-hour weeks sometimes, making minimum wage. But I think you really make a dramatic difference in people's health, and especially in orthopedics, it's all about pain and function. So we're getting people back to walking, people recovering from a major trauma. It's a really optimistic field. I think if you're at all thinking about going into medicine and you have an interest in science and medicine, just kind of spend some time in the hospital. If you run into an orthopedic surgeon or orthopedic resident, they're always willing to have you lend a hand, hold the limb, help get cast materials, things like that. I mean, it's sort of a task that requires a lot of assistance. So you can always get your hands dirty and get some more experience and figure out if it's something that you like. But, I think if you get an interest in it and it's something that you're passionate about, I think it's definitely worth the long haul. So
excellent.
Yeah.
Well, thank you so much for joining us here. We appreciate being on the podcast.
Yeah, thanks. Appreciate it.
Awesome.
Yeah.